This is our time.
是。
So good morning. It's our pleasure to be here. This is the first case for transmission from Nanjing First Hospital, China. And I'm Dr. Fei Ye. I will introduce today's operator team, Dr. Yu Wei, and his team. So Dr. Yu Wei, would you please introduce your heart team?
Okay, thank you, Chief. Good morning. This is the lab 4 in Nanjing First Hospital. I'm Dr. Yu Wei. Very lucky to show you this lab case. First, I'd like to introduce our team today. Gan Jinxiang, the two mates will assist me to perform today's lab case. And we also have our head technician, Dr. Pantong, to be our IVUS interpreter. And we also have the two nurses here. Thank you all. First, I'd like to invite Dr. Wu Xiangqi to give you a case introduction. Dr. please.
Good morning, honorable doctor. It's a pleasure to the patient's information. Patient, 67 years old, female, recurrent chest pain for 6 years and grade for 1 month. Risk factor is hypertension, diabetes. The test result shows low EGFR and the BNP is normal. ECG showed T-wave inversion, ST dispersion is led to 3, the AVF, V2 and V6, and the normal EGFR fraction. We diagnosed patients unstable angina pectoris, hypertension, diabetes. Next. From the LAO cranial position, we show the RCA is diffuse lesion with a serious narrow lesion. Next. From the caudal and IO cranial position, we see the LCS is borderline lesion and the proximal OAD is a serial narrow lesion, and the middle of the LCAD is CTO with calcified lesion. Next. We also see the LAO cranial and the spinal position. Further test the above mentioned lesion. Next. Then we calculate the test score and the CTO. We find that the score is very high. It indicates the lesion is very complex. However, the patient related to a cell cabbage and the patient's age is high. And eventually, the patient to the PCI. Next. This our strategy refers to the solve the RCA diffuse lesion and the guidance, and we use the average guidance, the LAD LED CTO. CTO's strategy integrates or retrograde after the opens the CTO. How to treat the calcified lesion, rota, or short-wave balloon. That's all. Thank you very much.
Okay, thank you, Dr. Wu. So as you see today, our case is the trap vessel disease, and I think you'd like to see our today's angiography. Please show our today's angiography. Go to the first one, please. Although the patients has the high risk level from the syntax score and it's the good candidate for the cabbage, but the patient family refused to perform the open chest surgery. So the family is strongly against cabbage and ask us for help. So for the trap lesion, we have the pre-procedure preparation. And first, for the procedure, although it's the equivalent coronary artery, but you can see from today's angiography, the right coronary, the flow is not good, and you can see the comparable flow from the both the side, because from the the postlateral, you can see the contralateral flow just from the circumflex to the PLA. And the left main is the Medina 010. It's not the true bifurcating lesion, but very long diffuse lesion from the ostium of LAD and extended to the distal LAD. And also you can see the CTO in the middle segment of the LAD. So it's really a tough case. And before that, our team, we just compare both of the side of the anatomy, and we just equivalent the beneficial and the risk ratio, and we decided to treat the ICA. The main reason is just because the ICA is the recipient vessel. You can see the donor flow from the circumflex. So if we want to PCI for the left coronary artery, and the circumflex is a dominant vessel. If the circumflex flow compromised, there will be a jeopardy for this patient. So ICA treat first, I think, is suitable and will be safe. This is what we did today. Okay, just show the next picture. You can see the wire, and this we use the transradial approach, use the 6 branch. It's the M plus 0.75 and use the 2.0 and 2.5 balloon to pre-dilate the diffuse lung lesion just from the distal cracks to the ostium ICA. And the balloon expands well, and you can see flow also good. Patients tolerates well, and then we deployed the 4 stents just from the distal crux and to the osteo ICA. And the diameter of the stent just from the 2.25 and to the 3.5. Then we perform the post dilation, and you can see the final result of the ICA. For the IC PCI, we totally used nearly less than 15 minutes, and the contrast volume less than 50 millimeters. So I think the patient is still well, hemodynamic stable. I think that will be good support for us to perform today's the tough case, the tough bone of the left coronary artery. So you can see the final result I see. Although you can, next please. Okay, it's the, you can see is the bilateral coronary angiography, because of the total occlusion in the middle segment of the LAD. But unfortunately, we seek to find the contralateral from the distal PTA usually. It's also the common contralateral from the PDA to the just from the septal and then to the LAD. But because it's the equivalent distribution of the coronary artery, so we cannot find the contralateral collaterals from the distal ICA. It's fortunate. And the main the collateral is just from the ipsilateral from the obtuse marginal and to the second diagonal. And it's also the common epicardial collateral for the left coronary artery autonomy. But just is the although the JCTO score is nearly 3, right, Dr. Is 3. Yes, so it's middle to high level. But I want to try use the anti-grid wiring. Then if the anti-grid wiring not succeed, I just to change my switch to my next strategy from the retrograde. Just to use this the challenging epicardial collaterals. So next, please. You can see from this the IO cranial. You cannot see very clearly the contralateral from ICA. Next. Okay, next. Okay, next. You can see the osteo LAD also sharp lesion, just because we just avoid the ischemia when we perform the LAD middle CTO PCI, and we use the 2.0 balloon next to pre-dilate the osteo lesion. This is 2.0 balloon. Next, please. Okay, seems better. Next, please. Okay, this is the wire, and very difficult. And when I want to retrieve the wire, I feel just the resistance, like the something bites the wire. According to the my experience, that called the proximal segment of LAD, there must be some severe calcified plaque and also the very tortuous lesion. As you can see, the wire cannot extend the vessel to the street. It's calcified and also tortuous. Next, please. Unfortunately, you can see it's the fine cross microcatheter. Just want to follow, but you can see it's not succeed, cannot pass. And also the sharp lesion also has the calcified plaque. So next, please. I use the 1.5 balloon to pre-dilate. Next, please. Next, please. Next, please. You can see balloon not expand well, and also you can see the contrast staining. Seems that the lesion is very tough. So next, please. Try to use the double lumen catheter, the KDL, but you can see the wire, the softer tip wire field XT cannot engage the ostium plaque. So next, please. So I changed the guide second, use the middle in the middleweight tip load guide wire. Seems better. Okay, next, please. But unfortunately, the double lumen catheter, you see, it just also feel the resistance, and also from the antegrade way, and also when I do want to retrieve this the KDL, I feel the strong resistance also bite the feeling. So next, please. So I just use a trapping balloon to retrieve the double lumen catheter. Next, please. Oh, sorry. Here is just what we do now, and I just successfully to switch our catheter from KDL to the fine cross, the single lumen catheter. Okay, Chip, that's what we did now, just here. So can you give us some recommendations, give us guidance for the next step?
So when we meet CTO lesion, very difficult lesion, we should make a plan before procedure. First, integrate wire technique or retrograde wire first, or with both. The second is which kind of wire you will use, hydrophilic wire or just like a puncture wire. So third is where is the entry point of CTO lesion? Can you see it clearly? Third, what will we do? Use a microcatheter or double channel catheter. The benefit of the microcatheter and compared with a double channel catheter, which is better for this kind of situation. So we should pay attention to a lot of key points before CTO lesion procedure. So what's the kind of the wire you use for the first wire?
The first field XT.
Field XT?
Yeah, right, soft tip.
So field XT, can the field XT find the entry point? No.
No, really difficult.
From the original angel, we can see maybe the entry point clearly from the AP cranial or RL cranial. We also can see the entry point. What's the reason of that? There is a very total routine of the proximal LED.
UB7.
UB3.
It's the guide second, Chief. So I just find that the wire is different from the first channel.
Yes,
I think it's not the good entry point.
Yes, we can see the wire can go through. Just look at the reference view. You can see the Gaia 2 can touch
UB3.
Can touch near the distal entry point.
Guide second, another one.
No, still Gaia second.
No, we don't have the other choice. Give me guide second, please.
So you want to escalation of the wire when you use Gaia 2. Gaia 2 cannot go through?
Because I think the wire tip got damaged, so I just want to change a new one.
Okay.
Yeah.
Still Gaia 2 or Gaia 3?
It's the Gaia 2. I don't want to escalation the wire tip because the Gaia second, the first Gaia second goes, I think, smoothly, just because the second wire is not in the previous channel.
So when you find the Gaia 2 cannot go into the distal true lumen, always go into maybe the side range. That means Gaia 2 may be in the subintimal space.
Yeah.
You can use a parallel wire technique.
But parallel, I think it's very difficult to perform the parallel wire because the very tight lesion, I feel the wire bites by the proximal segment. And even the double lumen catheter, when I try to insert and when I retrieve, the wire just cannot keep its place. So that's why I changed for the single catheter. If I failed, maybe I will try use the double lumen catheter to perform the parallel wiring again.
For the reason the proximal LED was very total, so it's quite difficult for us to use a single wire tactic. Sometimes we always use a parallel wire tactic. One is we don't have the UB3.
Yeah, we don't have the UB3 here.
Okay.
It's used a lot.
Yeah. For the CTO lesion with totals and severe calcification, it's quite difficult for us to perform PCI for the CTO lesion, just because the JSCTO score was very high compared with no calcification.
You not feel resistance and wire. You can still see the bands. I cannot follow the microcatheter.
Resistance may be better compared with the no resistance, just because the Gaia 2 or Gaia 3 in the subintimal space, we also cannot feel any resistance. So test for wire.
Okay, test please.
If the wire still in the fourth lumen.
Picture please, yeah. It's just different from the previous channel, yeah.
No, we don't know it's a 2 or 4 lumen. Just because with the reference of calcification, it's not. Maybe go a little distal.
Okay, I just try.
You're feeling any resistance or stuck feeling?
Not stuck, but bit resistance. I just retrieve use the reflection of this Gaia wire. Okay.
So if you want to perform parallel wire tactic, which kind of wire you will use?
I like escalation, maybe the more stiffer, just to find another channel.
Okay.
Yeah. Okay, doctor, please. Test, please. Test, please. Okay. Take a picture. Okay. Let's check. Please. Okay. Yes.
Change to RL cranial.
RL cranial, please.
So yeah. Yes. If two different angle view.
So, Chief, from this projection, I just think it's different from the previous channel. I just want to nearby the septal side. I think, I think that would be.
It's not in the.
Just because the band just cannot to change the y direction. Maybe parallel wire.
That's why I want to use parallel wire tactic, just because this wire can make the angulation.
Yeah.
Okay, leave the wire there.
Okay.
Okay, use another microcatheter with the side branch wire into the same LED. Then use a hard wire.
Yeah, Gaia 3.
Yes, Gaia
3. Okay.
So the experience tells if the first wire in the fourth lumen, just leave the wire there. The benefit of the first wire in the fourth lumen can make this is the marker, and the second, this angulation of the
trapping
can make more small. So make
just because of very sharp space, so it cannot tolerate the two. Although I use the self-range Gaussian catheter, CTO for the fine cross is also is suitable, but just the very sharp space cannot tolerate the two microcatheter. So CTO technique will not work, I think so. That's why I just want to retrieve the previous microcatheter.
This is 7-branch guiding catheter?
Yeah, 7-branch guiding catheter.
We can use 2 microcatheter.
Yeah. Just because the very sharp lesion there. The one microcatheter, I just feel
go through.
Yeah.
Okay.
So CTO, I don't think will work. Great. Sure. 12, please. Okay. Continue. Please.
Okay.
Okay. Flush the microcatheter, and I will use again. Okay. Okay. Done. Okay. Gaia 3, please. Gaia 3.
That's right.
No, where's the wire?
Yeah, I think so. I see.
Make sure maintain the wire in the
So Chip,
position stable.
should I use the KDL again?
No problem.
Oh,
You can
OK
use.
KDL 双枪尾导
So
管。
if
哎
I don't know, compared with microcaster, KDL can go yesterday or just
I cannot go to sleep, but just in the proximal segment and easy my proximal tracking of the wire.
okay, no problem. You can use a KDL.
KDL. So Chief, do you have the experience for the low profile double lumen caster like the Sasuke? As we all know, till now in our Chinese market, we have this we have this device now.
I think a lot of domestic company in China has a very good microcast double lumen caster compared with Japan. I don't have any experience. I also heard some experts working in China think that the local company double lumen caster in China has a very good.
Okay, as you see now, Chip, the KDL just go here, cannot go anymore.
Yes, sometimes compared with only single lumen microcaster, the profile was smaller compared with double lumen caster. So the single lumen microcaster can go more distantly compared with double channel. If there is a severe dissection occurred, I want to use a double lumen caster. If there is no severe dissection, from my experience, I want to use a single lumen. Yeah, single.
Okay.
So you can use. Just because we cannot push the double lumen caster more distantly, so the benefit of the double lumen caster, we don't have any benefit.
Agree. I just trying to advance more. As you can see, calcified and also
yes,
touches.
it's quite difficult. It's quite difficult.
I just want to deep see the guide and to give some support. Okay, seems good.
No.
Okay, it's in the small branch.
Just because the tip of the double lumen caster stop means the block the entry point.
You think
sometimes yes, we cannot get okay.
Seems the wire deviate from the previous. Hey, I think this is good. We could test, please. Test, please. Small test, please. Just want to confirm the wire direction. Okay, test, please.
Okay, it's better.
Yeah, it's the previous channel. Usually, I like use the more soft tip to, but as you can see, we only have the Gaia third here. So
you did not reshape the tip of the Gaia 3.
I give it's the previous shape, and also I give a small band.
No, I don't think you need to get another shape, reshape again. So previous shape is enough.
It's enough, okay.
For CTO segment crossing. You cannot feel any resistance?
No resistance.
Okay,
but
I don't think it's in the
channel. Take a picture, please. Okay, please. Okay. Separate the two wire, but deviate too much.
I think maybe the entry point is different.
It's different.
Yes.
Okay, so
maybe so you should pour the
back.
caster a little back.
Okay.
And use another still back.
Okay.
Okay. Try to go into no. It's the same place.
Yeah, the same place.
still, yeah.
Okay.
Maybe the space was large enough. We cannot find another space.
Yeah. So malleability becomes very difficult.
A little better? No.
Yeah, divided too much.
For the reason retrograde wire from the RCA was impossible for this case. We cannot see any collateral from the PDA to LED.
Yeah, the contralateral is not good.
The iliac collateral from circumflex is not suitable for retrograde wire tactic.
Yeah.
So anterograde wire tactic is very, very important and very challenging procedure for this CTO lesion. So it's quite difficult, just because the proximity was very tortuous and the calcification. We also can see the CTO score was very high. If still failed, we can use the third wire.
The third wire.
Yes,
okay.
third wire makes the parallel wire tactic. So this is a challenging case. It's a little better.
A few small resistance, but just two wire divide too much. I don't think there's a good channel. And
so, yes, I think the anti-grid wire tactic, it's a finger tactic, just because we can feel some resistance and some stuck feeling. That means maybe in the fourth lumen or in the true lumen there is difference.
I do believe it's actual plug tracking, not.
There's a lot of questions from audience. Did you consider IABP or LVAD devices for this patient? So the original data for this case, the EF value was normal, Dr. Wu?
It's 66%.
Okay.
It's normal.
How about the anti-pro BNP? It's normal.
It's normal too.
So the patient's original heart function was good. So if we pay attention to the heart rate and blood pressure during the whole procedure, the patient don't need to use IBP or LVAD routinely. So why choose the RCA first instead of LED? Dr. Yu, RCA first or LED first?
I think ICA first. ICA will be safer because I see the recipient vessel.
Yes.
We can see the contralateral from the PLV to the distal ICA. So that's why I decided to treat the ICA first.
Yes. We cannot see the collateral from the RCA to the LED first during just because the severe stenosis at the proximal part to the distal part of RCA. If we open the RCA first, we can see a collateral. That's the good chance for retrograde water. Or not for this case. Even though we open the RCA first, but we cannot see the good collateral from our distal RCA to the LED. So routinely, you can use treat RCA first, just because RCA we cannot see the distal flow was not good. The RCA receives the collateral support from the LCA. So we treat the RCA first. The patient can feel very stable when we perform PCI for the LED CTO lesion. Can both vessels be done safely in a single procedure? Dr. Yu?
This is why I doubt before the procedure, because for me, if the patients can tolerate the ICA PCI, I think continue to perform the PCI for left coronary, I think is also a good choice.
Yeah.
Just like the previous work, it takes only 50 millimeter contrast, and only the whole procedure lasts only less than 15 minutes. I think it's okay.
Yes, it depends on the procedure and contrast volume during the PCI for the RCA. If the time is very, very limited and the contrast volume was very small, So I think both vessels can be done for the same.
Although we rarely do this. Okay, I think this channel looks better, right? But still deviate from the distal.
So you can change another view.
Okay, another view, please. Another view,
So
please.
antegrade wire tactic, we should pay attention to the hematoma during the antegrade wire tactic. If we perform for several times, we can see maybe.
Please.
No. So when we change to RL cranial, we can see the both wire in the fourth lumen. So retry again. If PCI riskier in these patients than cabbage, Dr. Wu, could you calculate the syntax score before the procedure?
Syntax score indicates the cabbage have advantage over the PCI. However, the patient's family and the patient reluctant to accept the cabbage.
Yeah.
So this time we choose the PCI for the patient.
Okay. So when we talk with the patient and his family, the patient and her family reject to get the cabbage first. So we want to perform PCI for the case. If we still failed to open the LED, we can use a hybrid tactic. Use RCA PCI LED cabbage. We also open heart surgery.
Yeah, that's the another option.
Yes.
Before that, I just want to try our best.
Yes.
So, Chief, if the antegrade wiring cannot work, like maybe I want to try the retrograde way. How do you think?
Yes, you can use the retrograde wire tactic.
Okay. Because
yes, if you can make a lot of hematoma during the antegrade tactic, so you can start from the retrograde wire tactic. So if we perform PCI with a retrograde wire tactic, we should pay attention to the ischemic risk of the LED from the retrograde wire. Just because we perform PCI from retrograde wire with wire and microcaster in the retrograde wire collateral.
Right, because I think the antegrade, the axial plaque space expanded before the parallel wiring. So maybe antegrade will be not make any work.
Sorry. So there is another question. Would IVUS have here?
I don't think IVUS can follow. Maybe IVUS guided the antegrade. Maybe I think with the last Baylor choice according to my experience.
For the previous procedure of this case, even we use a microcaster, a double channel microcaster cannot push into the distal to the middle AD just because the lesion was very tough and the very totals. I think IVUS cannot go through just because the profile of IVUS compared with double channel microcaster, IVUS was larger. So I don't think IVUS here can be used or we can get the benefit from the IVUS here. We cannot see the entry point from the IVUS guidance for this kind of situation. So is the patient's kidney function normal, Dr. Wu?
Oh, kidney function is EGFR is low. Is mild decreased in EGFR.
Okay. So the EGFR was a little lower. Okay, between 6 to 90. Okay, this is grade 1, maybe a CKD. So we should limit the contrast used.
Test, please. This channel seems good. I need
change RL cranial.
RL cranial, please.
Just because we use angel-guided PCI, this is a 2D, but the Western was 3D.
Yeah.
Okay.
Also, yeah. The extra pack. Okay. So Chief, I like to try to use the retrograde.
Sure.
Maybe cannot work now.
Okay, no problem.
Okay. Before that,
So
because it's
yes.
only a 7-fan guiding capacitor, so cannot tolerate the KDL and also the another retrograde microcapacitor. I need to retrieve.
Okay.
Also, we can use the ping pong, but you see, when I want to retrieve this, this the KDL, I feel strong resistance. I should to put back the guiding capacitor and slowly retrieve. Oh.
This pressure is
Yes.
good.
I see. Maybe deep seat. Okay.
Okay. Yes, normal.
Yeah. Just leave the 2 wire here. Give me the 2.5 below. Use the trapping to retrieve this one.
Already.
Just prepare the 1.7 Chinese domestic microcapacitor. Also used for the retrograde. 1.7 of the Apple APT instant pass, please. Very strong resistance. Okay. 1.7of the Apple APU.
So how about the ACT?
ACT more than 400.
Okay.
Yes, I think it's okay.
If we perform PCI for CTO lesion with a retrograde wire technique, we should pay attention to the thrombosis during the procedure. Just because we use a longer microcatheter, with procedure time was longer.
Okay, study.
Wait a second.
Okay.
Oh, very strong resistance. Okay, you can see the wire kinked when I try to retrieve this catheter. Stuck.
Why not?
Okay. 等一下，这个去哪拿走？OK。That's okay. Okay, give me the
Spider?
No, caudal piece.
Caudal?
Caudal piece.
Caudal AP?
Caudal AP.
First,
yeah,
you
because the
you should make the wire in LED proximal first. There is a marker. So use a single lumen microcatheter.
Single lumen catheter, I think so.
So you don't need to use a 2 wire in the LED. Which kind of wire?
Because just when I want to retrieve the KDL, it's bite so strong, so I just lost my wire position.
Okay.
Yeah, now I just want to deliver the wire.
Yeah, it's okay.
Even use the retrograde, even try to use anti-grade approach, we also need the anti-grade preparation. So keep the wire here. Okay, another run through piece. Another run through.
Run through.
Another run through.
New one. You mean new one? Okay. Run through.
So we should review the previous angel.
No, I give you a new picture. Because the main is from the obtuse marginal.
Run through.
Okay. 回到碗1.7 ，please。拆了吗？1.7 1.7，赶快给你套上去。Prepare the CN wire. 往后拉，往后拉，往后拉。
It's not out. Okay.
Okay, 往后拉。
Okay.
Okay, we're back. Okay.
Okay.
Yeah.
Okay.
Good. Because the instant pass 1.7 French has the very small profile, the small tip, and also the passing profile.
So this is a domestic?
Yeah, domestic. From APT.
Okay.
Okay. So that's why I treated the ICA first, just because I just plot the procedure. My strategy is if the antigrade wiring failed, we will use the retrograde way, and circumflex will be our choice. If we leave the ICA alone, and there will be a jeopardy for this patient. So now I think it's no problem. Okay. Yeah, I will follow the market, also very cautious, but okay, you can see the tracking of the market is good. I need more support for this. Okay. And okay, give me the LO cordova, 左头位. I perform the tip injection. Okay, microcaster, please. Microcaster. Yeah, contrast. Yeah. 两毫升空针.
Show me
Give me the
previous,
pure contrast, please.
show me the previous same angulation angle.
Okay. Okay, please retrieve the wire. Retrieve the wire. Retrieve the wire.
Okay.
Yeah.
Okay. Okay.
Okay, thank you. Okay, I will take a tick injection for you. But not,
Like, yes.
yeah, but not very clearly.
Now we can see it.
Yeah, I will. From the guiding caster. Because we rarely use the surfing technique for the.
We don't need to use the surfing.
Yeah.
Surfing is for scepter.
Okay. Okay, give me the CN wire, please. CN wire, please.
Yeah.
CN wire, please. Very cautious. Yeah.
Yeah. Sound wise.
So, Chief, do you think we have any other option for the collaterals? Or do we need to use the surfing from the distal IC because even the septo zero collaterals always work. Sometimes work, not always. Yeah.
After still failed with collateral from the circumflex, you can use a surfing technique for RCA. It's just a try. We don't have any. Very tortuous here.
Yeah, very tortuous. Okay.
Previous angel.
Yeah.
Very, very tortuous here.
Yeah.
You should reshape the tip of the wire.
Okay.
Give me more bend. So previous angel, please.
Okay.
Yes. You can see the collateral was very, very angulated. So we think.
Just try. If failed, maybe I will switch to another strategy.
No, if still failed,
这是
use
苏俄03吗？
no.
像
苏俄 03。
03。
I think for the very tortuous epicardial Su 03, I think the soft tip, I think will be very safe.
Push the LED wire a little distant.
A little distant. Okay.
Yes. Yes. Okay. Yes. Got it.
It work.
Yes.
Okay. Previous view, please. Always go.
Maybe.
Maybe go the distal one. Yeah.
Maybe.
Okay.
No.
Yeah, I see.
Change a new one.
Okay, new one, please. Yeah. It's over rotate
Yes.
of the wire. Okay. Very tortuous. 撤掉这个，新撤 please. Okay, new one, please.
Maybe use the Sur 03 wire. It's yes, it's a soft wire. If we push a little distantly, we should push the microcaster more distantly
Okay.
to get more support from the microcaster. So
Talk a
compared
bit.
with Xi'an, so swirling sound was too small, was too soft.
Yeah.
Yes. Okay.
Yeah.
Okay.
Seems like the same channel.
No. Yes. Good.
Okay, the up one.
It's better. So you can push the microcaster a little distance.
Okay.
Yes, it's better.
Okay. Okay, the previous view, please. Previous view.
Very tortuous.
Very tortuous.
Yes, very, very tortuous here. No.
Yeah.
No.
Yeah.
Change another
Okay.
direction. Yes, change another direction. No. Put it back to find another entry point. Means proximal part. Yes.
Okay.
Yes, here. Try another
Maybe I have several
branch.
with branches here.
Yes.
Yeah.
Another branch here. So put it back microcaster. to find another branch or still. Yes, already the back, still back,
Okay, back.
still back, still back. Yes.
Okay.
The wire is back. Then yes, try. The same
Yeah,
branch.
seems like the same channel. Maybe the
same branch.
yeah.
You can show the previous angel again.
Previous angel, please.
Yes, previous angel again. No, retry again. Okay.
Okay, this.
Here. Maybe.
Small branch. Okay.
Yes.
This will be
maybe.
Yeah, this will be better. Oh,
push. No. If you find a resistance here, you can push the microcaster a little distal, get more support from the microcaster. Just because this is 403, it's very safe. Oh no.
Yeah. Very touches.
Yes. How do you think about the tip of the wire? Still
I just
good?
cannot. I just cannot to. It's too much pushment. Only a bit one.
So retry to find the newer branch.
New branches. Okay.
Yes, it's quite difficult if you cannot go little distally. This is branch is not suitable. Still resistance, you can push the microcaster distally. Is the same inside?
Yeah, the same prism, but maybe small branches hinder the wire checking.
So compared with septal collateral, so epicardial collateral was always very total. And if the okay, oh no, I don't know.
Too many small branches here.
There's a lot of just maybe a small branch. Angulation between the main vessel and the branch. Maybe the wire easily going to the. How about here? No, it's not good. Okay, no.
Yeah. Okay, the same channel.
So yes, for original, here you can find another branch here.
Okay.
Yeah. Okay.
Oh. A bit more. Okay.
Here, just because this the tip of the wire got yes, I think the reason of the high resistance here is just because angulation.
Yeah, angulation. If it still doesn't work, so septal surfing. Okay. Okay. Yeah. Okay, okay. Okay. I'll take picture from the ICA. Not good. Only step to 0, but doesn't mean we don't have any choice. Okay.
Look at the distance.
Distal. I think maybe there is one branch, right?
Yeah, try.
Okay, okay.
After the RCH held good the blood flow, I think the cell branch to nutrition the LED will be good in the few months.
Yeah, maybe.
Yeah,
Maybe.
it's another option to you can use the retrograde to yes
That one.
okay.
Some people like to stage the PCI for LED CPU limited after the canalization, request regarding from the RCA first. If we waiting for several weeks, we can good network from this RCA to the use this angulation, you can find look at the proximal branch.
Okay.
You can find the proximal branch. Is that
So maybe there's a distal one.
maybe?
Yeah, distal one, I think. Yeah. Before that, I will make sure that the epicardial will be okay. Seems no damage from the. No, no contrast, the staining or perforate. I think it's okay. Okay, try use the surfing technique from the distal PDA. Yeah, previous view, please. Okay. 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 Give me microcaster. No, this one. Just use this one. Want to save money for the patient. Okay. Okay. Go.
12,
12, 12, please.
12,
12, 12, 12, 12, 12, 12.
12, 12, 12. Okay.
Okay.
Use a longer microcaster.
Yeah.
1.7.
Maybe 1.7 French.
Yes.
But 150 centimeter is enough. Okay.
Just from the angel, we can find the just
回到缓冲好给我 please.
septal collateral was very small. Maybe we can use a smaller profile microcaster.
Yeah. Oh.
Yes. Okay.
Okay. Microcaster, please.
So previous angel.
Yeah. And prepare a new SWO3. New one, please.
Previous one. Previous one. Previous one. Yes. No. Use.
We only have CR, right? Okay, give me CR. No.
Pay attention. Wire.
Wire, please.
Okay. Hold the wire.
Okay.
Where's the microcaster?
Yeah. Blow. 25 blow, please. 25 blow. 25 blow. 25 blow. 眼里有枪。
Frozen it.
Is the trapping.
Previous one? No, still
Because,
previous one.
Yeah, maybe.
Previous angel? RCA angel. Yes, here, frozen. Okay, enough. No, it's not good. Okay.
New one, please. 2点有普通球了 please.
New one.
2.5普通球能，give me。接上折空，全屏。OK， 12 checking， 全屏。Extension Y， 台上那个延长导丝呢？小甘，这里头的 Extension Y 拿走，必须有。OK，go， 拿走。OK，Extension Y please， 那个延长导丝给我。不是延长导丝，插在那个 apt 微导管里头的延长导丝。Yeah, right. Because just the 1.7 French microcapacitor maybe damaged the field resistance where I want to retrieve the wire, so I use the extension wire to deliver this one. Oh, not one, not good. 新的6万，微导管给个新的，还是导丝的问题。延长导丝还在吧？延长
You
导丝
also can see
extension wire，
the
延长导丝
patients were stable during the table. The heart rate and blood pressure was very,
拿
very
导丝，这个导
stable.
丝给我，拿微导管。
So even though because we want to use a distal septal branch, the diameter was very, very small. If we want to use a microcaster go through the collateral, we use a very lower profile microcaster.
New one.
The smallest profile microcaster in China is 1.7 French.
Yeah, it's the smallest profile.
Some company has 1.6.
If Caravelle, I think will be X better because more smooth. 微导管穿进去 ，please. Okay.
Show me the previous angle.
Okay. 里面有人放前一张造影。
Yes. Previous one. Yes, here.
冲过了吗？这微导管 ？Flush.
No.
给我。
This is the same 1.7 French microcaster
Yeah,
from
right.
APT.
Okay.
This is a domestic microcaster.
Suitable for the surfing technique. Low profile maybe better. Although we can use the channel dilator microcaster like the Corsair.
So what's the guiding caster used for RCA?
If I see the unfortunately the cell just because
Cell.
Yeah, very short or short right sinus.
Oh, a little difficult for the Richard Goodwine tactic for with a cell.
Yeah.
Okay. I don't use the previous wire in RCA.
Because what I think is maybe some damage of the wire.
Oh.
Yeah. Okay.
Okay. Same position.
Yeah.
Okay.
Okay, give me the same wire. Xiang, please. 撤导丝。 先挖呀，注意一下。
这样。
嗯哼。
So previous
No,
angel?
this is the. Give me a new CR. This is the extension wire. CR, please.
Yes.
Oh, here,
No,
here. I
no.
see. Here, here. The chip maybe use the distal one, right?
Distal.
Distal.
The angulation and the ostium scepter was not very clear from the angel. It's a little difficult.
Oh yeah, I know. Maybe tip injection not work, so just use the surfing. Yeah.
You will find the scepter first, then use the surfing. If
Okay.
you cannot find the same place, same position.
同一体位吗，同志们
Yeah, yes,
Okay,
center.
Okay.
Okay. Center. Angel.
okay.
嗯哼
Okay. Yeah, yeah. No. No. No,
Yeah.
no, no, no.
Yeah.
It's in the ventricle. The test of oil. RC, RC. I don't think it's no, no, no. Look at
Yeah.
the tip of the wire was
Yeah, I think so.
floating. So I think it's in the ventricle. Put it back to find another. No.
Yeah. Okay.
Yes. Yeah.
Okay. This better, but
No. No.
It's very much.
Yes. No. 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 Go
okay.
it back to find another one. Yes. You can find the ventricle. Okay. Maybe better.
Yeah.
Maybe better. Try. No.
Not good.
Still fail to use another new one. New wire.
New wire, please.
New eye. Xiang.
Okay, 3 minutes.
Okay.
Xiang. Flash.
Just because the case was very tough lesion with LED CTO lesion, we don't have any chance for perform the retrograde wire tactic from the LCA circumflex to the LED and also from the distal RCA to the LED. So anti-grid wire tactic is very, very challenge case for this. I think the scepter is good. Try waiting for a while. Even though we should spend a lot of time, maybe the procedure get more longer and longer compared with the conventional PCI procedure. If we want to perform a long time, we should pay attention to the patient's symptom and the contrast volume during, just because the renal function was the patient was a mild diseased. Yes, I can find.
Very.
No, very
Yeah.
totals here.
Very touches.
Just because the distal scepter was very small.
Oh.
No.
Yeah. Maybe to the chamber.
The ventricle.
Yeah. The ventricle chamber.
No.
Maybe in the ventricle chamber. So
Yes, you can you find another.
another one. Yeah.
Yes, another one. If we want to perform a surfing technique, that means CC grid was 0. So we cannot clearly from the distal RCA to the LED. We can try for many times for different sector.
Very touches even
Yes.
for the septo.
The another question is for this case, we cannot see any collateral from the maybe proximal part of the PDA. We also can find many small collateral located at the distal part of the PDA. That's not good, suitable for rich grid wire tactic. Even we use a surfing technique. So the epicardial collateral from the circumflex to the LED was very total. We also can see it clearly from the tip injection. That's why we cannot successfully use a rich grid tactic for this case right now. Maybe we can spend a lot of time, a lot of times